Medical devices are part of our daily work. We often take their performance for granted. However, sometimes they don't perform as expected. The following case scenario demonstrates the role of clinicians in recognizing and reporting medical device problems in order to ensure patient safety.
Okay, that's all for me.
No, we have to practice.
Grammy's gotta go lie down for a minute.
One more song.
Oh, no. Grammy feels just a little bit tired.
How about for Elise?
Oh, we're not taking any requests.
What's a for Elise?
For Elise. It's a song Grandma taught me when I was little. She used to play it for me all the time. It's very pretty.
Here I am, about to drop over from exhaustion. Okay, ready?
Okay, Gwen, it's got to be something pretty major for you to call risk management. What's up?
Hi, Brenda. You're right. I've got to tell you about one of my patients today, Mrs. Crowley. She came into the ER with symptoms of heart failure. They did a chest film, gave her Lasix, got some labs, and sent her up to us in CCU. When she arrived, she was pale, short of breath, elevated heart rate, slight pedal edema. We placed an A-line and a Swan-Ganz.
What kind of swan did you put in?
Just a regular Swan. We were only interested in heart pressures. A-line is 90/50. And her last wedge pressure was 10, CVP 9.
Wedge 10, CVP 9?
Yeah.
Seems a little low, are you sure?
I'll re-zero it.
So you re-zeroed the swan. Did the numbers change?
No, they're about the same.
So then what did you do?
Well, Dr. K ordered a 500 cc fluid bolus followed by 125 per hour drip.
Did it help?
No. In fact, she was worse off than when she came. She was full of fluids, having trouble breathing, and she started having EKG changes.
So what were we doing wrong?
Dr. K, Mrs. Crowley is getting worse. Her lungs are full and her SAT is dropping.
Let's go look at her. Miss Crowley, are you having a hard time breathing?
Yeah, it's getting harder to breathe.
Looks like her ST is elevated. Let's get a 12-lead EKG.
I'm gonna go get an EKG machine. I'll be right back.
Am I gonna be okay?
Oh, yeah, you'll be fine. I just want to get a different reading, that's all.
Dr. K, here's Mrs. Crowley's 12 lead.
Oh, thanks. Compared to the one she had in the ER when she first came in, she's much worse. We need to get her into the cath lab right away. We've been pumping this poor woman with fluid, now she's overloaded.
I'll be right back and get her ready. When they did her cath, her pressures weren't low. They were really high.
How high were they?
The cath was up to 24, the CVP nearly 30.
So how can that be if her pressures are really low here and really high in the cath lab?
You know, we had a similar problem to this last week with a patient we took to surgery.
Which patient?
The abdominal aneurysm in bed 6. When he was down here, his swan pressures were low. But up in surgery, they said they were sky high.
So what was up with that?
Apparently, they had to switch out the cable in OR. And when anesthesia brought the patient back, they said there might be something wrong with our cable.
Oh, by the way, there's something wrong with this cable. We had to switch it out.
Okay, we'll take care of it.
Anything else?
No, thanks, we're fine.
And then what did we do with the cable?
You know, I'm not sure. Oh my gosh. It must have gotten cleaned and put back on the shelf. And then I must have used it on Mrs. Crowley.
Dr. Davis, telephone, please. Dr. Davis.
Dr. Kimmler, can I talk to you a minute about Mrs. Crowley?
I didn't do it.
No, seriously. It looks like we were treating her low Swan-Ganz readings when in fact we probably had a bad transducer cable.
What do you mean a bad cable? You know, her numbers didn't quite fit the picture, but they're all I had to go on. If I had had accurate numbers, I wouldn't have given her fluids, which only made her condition worse, and maybe she wouldn't have ended up in the cath lab. Okay, now what?
Well, our primary concern is always the patient, and she's fine, she's stable. We'll deal with the family later, but we need to learn from this experience. The bottom line is, when we have a medical device issue, we remove the device from service, we report it, and that way situations like this will never happen again.
What is your role with regard to medical device safety? Sometimes we get so busy in the course of our daily work that we don't recognize actual or potential medical device problems. You have an important role to play with regard to the safety not only of the patient that you currently have, but of patients you may never see. An easy way to think about your role is to think about the 3 R's: recognize, remove, and report. First, recognize that any time a medical device is involved in either an adverse event or a near miss, that device may have contributed to the actual problem that occurred. Medical devices involve all kinds of things that we don't even think about, such as bed rails, scales, bathing tubs, computer software and hardware used in patient care, maybe even disposables and implants and reagents. Also, the kinds of problems involved with medical devices are more diverse than just performance problems. There are problems in packaging, problems in instructions, interactions with other devices, computer software glitches. Once you recognize that a device may have been involved in an event, then remove that device from circulation. It's not your job to determine whether or not the device has a problem, but it is your job to ensure that no patient is injured by that device until a determination can be made. Finally, report according to your organization's policies and procedures. Give as much detail as possible so that your risk management staff and biomedical engineering staff can determine if the device has a problem and what contribution it made to the event. Please remember, patient safety is not a program, nor is it an activity. It is the framework upon which we deliver care.